we do that. So are we ready to start?
I think it's time to go, Gary, if you want to lead us off.
I will say a couple of words. Well, first of all, I want to welcome everybody to the North New England Clinical Translational Research Seminar Series. I'm welcoming everybody on behalf of my partner in leadership for the program, Cliff Rosen, myself, Gary Stein. We basically cover Vermont and Maine. And it's a program which I'm sure many of you are aware is set up with the objective of improving health and healthcare in northern New England, particularly rural northern New England. What I'm going to do is to ask Michaela Reagan to go ahead and to introduce the speakers. So why am I doing that? Because Michaela is a person who, for her graduate career, her postdoctoral career at Dana-Farber, and now as an independent investigator for what, about 5 or 6 years now, I guess, at Maine Medical Center, has developed a program which addresses a very key problem in cancer, and that is she is working on myeloma and trying to understand mechanistically the bone microenvironment and the relationship between the cells that inhabit the bone microenvironment, tumor metastasis to bone, and how crosstalk between the myeloma cell and the other cells in the bone microenvironment are going to make a significant difference in terms of the onset, progression, and management of the disease. And she's doing a great job of it. She truly is. So let me turn it over to Michaela, and she's going to introduce the folks who have the leadership role for the cancer plan in Vermont, New Hampshire, and Maine.
Wonderful. Thank you so much, Gary. That was a really nice intro. So I'm just going to be the moderator for today. I'd like to remind everyone that the speakers are going to talk for 15 minutes, and then we'll have the Q&A session at the end for another 15 minutes. So, of course, please mute your microphones until the Q&A. You're welcome to utilize the raise hand function in Zoom. You can also put questions in the chat, and we can ask them. I'll ask them at the end if you're not able to. So our panel consists of experts from Maine, New Hampshire, and Vermont, and will include plans for recovering, sustaining, and accelerating the momentum in cancer prevention, early detection, treatment, and survivorship over the next 5 years. So our first speaker I'd like to introduce is Melanie Feinberg. Melanie is the Comprehensive Cancer Control Program Manager at the Maine CDC. As an experienced health system manager, Melanie was the Director for Oncology Quality at the Maine Health Cancer Care Network prior to joining the team at the Maine CDC. Melanie has participated in numerous program initiatives aligned with Maine's Cancer Plan and the Commission of Cancer, or the COC, Patient Care Standards. Melanie has been an active member in Maine's Cancer Coalition since the publication of Maine's first cancer plan, which was in 2001. And she's very excited about the release of the cancer plan for 2021 to 2025. As a working member of the coalition's many task forces, she has collaborated on oncology initiatives across the care continuum, all the way from prevention to screening and early detection, treatment and shared decision-making, and palliative care and survivorship. Our second speaker of the day will be Sharon Mallory, who has a Master of Public Health and has worked as the coordinator for Vermont's Comprehensive Care Control Program since 2011, providing overall program management and leadership to manage the implementation of the Vermont CCC program. So this includes oversight, execution, and maintenance of Vermont's cancer plan and collaboration with membership on the statewide cancer coalition, Vermonters Taking Action Against Cancer, so that's the VTAAC, and others. Sharon also works to build and maintain collaborations with a variety of partners to affect Vermont's cancer burden with a focus on policy systems and environmental approaches. So prior to her work at the CCC, she worked for 6 years with the Vermont Department of Health Tobacco Control and Prevention Program as a community tobacco control specialist, coordinating and managing activities of the 17 state-funded community tobacco coalitions. This included consulting with tobacco coalitions to assist with their annual development of the community work plans, providing training and technical support and efforts to affect secondhand smoke community policy change, and facilitating program development, implementation, and coordination strategies with many partners. Sharon received her MPH from the School of Public Health at UMass Amherst and her BS degree in bioscience from the University of Vermont. Our last speaker today will be Adriane Burke, another Master of Public Health She's the Cancer Programs Manager for New Hampshire Division of Public Health Services. Adriane has spent nearly a decade now working across the cancer continuum. She's currently responsible for the management and coordination efforts of New Hampshire's Comprehensive Cancer Program, Breast and Cervical Cancer Program, and the Cancer Registry Program. So prior to working at the state, Adriane worked at the American Cancer Society's Cancer Action Network, which is a very comprehensive network that involves basic scientists and clinicians and providers to develop and advise on federal and state policies. These are all related to cancer screening and prevention. She also spent time working at the NCI, the National Cancer Institute, on health communication research related to cancer screening. So these are some very experienced speakers that we have today, and we're very lucky to have them. So welcome. And I'm going to let you share this, take over here, Sharon.
Okay.
Go for it.
We switched it around. I'm actually starting. My name's Sharon Mallory. Melanie is going to go after me, and then Adriane from New Hampshire is going third. So sorry, that's a little confusing. But hello, everyone. I'm sharing my screen, so I can't see everyone's face, but it's great to have so many people here. I know some of you. As Michaela said, we're talking about comprehensive cancer control in northern New England, and I'm going to start us off with what we're going to talk about first. So first, I'm going to talk about what is comprehensive cancer control, so you know what we're talking about, and then we're going to sort of break into our state presentations, where I will spend a few minutes talking about Vermont and the 2025 Vermont Cancer Plan. Then Melanie will talk about Maine's Cancer Partnership, and Adriane will talk about cancer control actions in New Hampshire, and that'll sort of give you a good overview of some of the work being done in northern New England. So comprehensive cancer control, what is that? And as I think was alluded to earlier, you know, it is or you may have overheard earlier before we officially started that the Centers for Disease Control and Prevention funds all 50 states and a bunch of territories and tribes to do comprehensive cancer control work. In Vermont, Maine, and New Hampshire, the funding is received within our health departments, which have various different names. But the work has been around since 1998, and is really, the goals of the work are to address cancer across the continuum through facilitation of partnerships, sort of trying to coordinate overlapping initiatives to have a better impact on the cancer burden in states, territories, and across the country. So that is what it is. It's not easy to drill down into the details, but here are a few more points that might be helpful, and that the key priorities for all comprehensive cancer control programs are to develop and implement cancer plans, so a state, local, territory cancer plan, and in Vermont, it's the Vermont Cancer Plan, to support in some way, sometimes financially, sometimes organizing, active cancer coalitions or partnerships to coordinate the work. A big priority is health equity, which I know we all hear about through various channels, not just through cancer. And then really the overarching theme is to really address cancer across the whole continuum. So we're not honing in on one particular area, but really to have a focus to address cancer from prevention to end-of-life care. And as I sort of noted at the bottom of the slide, really all of our programs are slightly different. We all do all of that work up above, but depending on the state, the communities, or the resources, the data, we set different priorities and organize our programs in different ways. So you're going to hear today about northern New England states. We're all fairly, similar rural states. And so I think we actually are fairly similar in our approach, but not completely similar. So I'm going to start out and talk about Vermont and the Vermont Cancer Plan. And I always like to frame out my presentations with a little bit of data and why we're doing this work. And this is our most recent statewide data through vital statistics at the health department. And that shows that cancer is the leading cause of death in Vermont, at least it was in 2019, and it's closely followed by heart disease. Sometimes those two switch. They're very close. So it's chronic diseases, very significant leading causes of death in Vermont. Many of the factors that cause cancer are also related to heart disease. So it's a very, it's a big impact here in Vermont and across the country, really. I also wanted to sort of throw out just that we are, health equity again is a big focus, and we know that there are certain Vermonters that are more likely to be affected by cancer and other health outcomes due to disadvantages sort of that are outside of their control, and that is something that we at the Department of Health and in our cancer programs are really trying to impact and design our programs to try and level the playing field for everyone. So Vermont's comprehensive cancer control approach is just like the CDC guidance is providing. We do have a Vermont cancer plan, which is our sort of our guide, our blueprint for addressing cancer across the continuum. We have a statewide cancer coalition, Vermonters Taking Action Against Cancer, or VTAC, we call it, that sort of is active and coordinates the implementation of the cancer plan. You see their logo here and their logo on our cancer plan. The Vermont CCC program, which is housed officially out of the Department of Health, and this me and some other very part-time staff, a small program, but we coordinate and we work closely with VTAC and support them to do this work. And then I wanted to throw in a bullet here around evaluation, measurement and evaluation. I'm not going to hit on it very much in the presentation, but it is a key component of our work, measuring our outcomes. Not always hard when you're trying to measure partnerships, but measuring what our impact is and trying to pivot and be as sort of evidence-based driven as we can as we try to do this work. So just getting at the cancer plan, this is our 5th cancer plan. It was published in December of 2021. It's a 5-year plan, or almost 5-year plan. You'll see in these bullets that it took us a year and a half to develop this plan. COVID-19 has impacted a lot of things, including our work at the Department of Health and through VTAC and many of our partners. And so it took quite a bit more time to facilitate the plan, the creation of the plan. The development of the plan, and I know our other state plans, really involves a lot of partners. It's not just the health department saying we need to do this. And so it was really, it's a process where we're all contributing through various meetings, many of them online. It had to be pivoted to be online. Surveys, individual conversations, emails to really collect input, set our priorities, set our goals and objectives through a collaborative process. We had over 200 people, and it's hard to measure really how many people were, participating in the process. And we ended up, we're across the cancer continuum. So we have 14 goals, 3 objectives, and 78 strategies. It's a lot. I had to add those up when we were done, but it's a lot, and that's even fewer than our last 5-year plan. We were trying to be even sort of more narrow and specific, but it's hard when you're trying to address cancer broadly. So just sort of like, what is the cancer plan and what's in it? This is an example of one of our goals that's in the plan. We don't have to go through all of it, but we have goals, objectives, and strategies for each cancer topic area that was selected. We have the goals, sort of the broad thing, what do we want to do? And then objectives are measurable objectives based on data, statewide data, that sources that we have. Measurable objectives with targets, our 5-year targets for for what impact we want to try to make. In this case, it's increasing the colorectal cancer screening rate and decreasing the rate of advanced stage colorectal cancer, incidence diagnosis in Vermont, very linked measures. a lot of those aren't going to change a lot over 5 years. We're not always going to be able to measure our impact. Like, is it what we did to make that change if a change was found? And so then we have strategies that are sort of like, this is the activities, the things that we focus on to impact the goals and objectives. So these are evidence-based approaches that our coalition is working on, our partners are working on to try to sort of make a change in that cancer measure and reduce the burden for all Vermonters. So again, we go back to health equity. It's a big focus for us. In our new cancer plan, we have identified 4 key areas of focus: Black, Indigenous, and people of color Vermonters, lesbian, gay, bisexual, transgender, and queer Vermonters, Vermonters living with disabilities, and low-income Vermonters. And really an overarching theme, which sort of relates to your world, is rurality. Vermont is mostly rural, some would say all rural, but really it's also an overarching theme in our work and how we're measuring our progress and looking at the burden across the state. So these, I'm not going to get into the detail about why we selected these populations, but we know that the data sort of shows in Vermont, regionally, nationally, that these populations of focus are more likely to have poor outcomes. I threw in a couple sort of data points here that are actually thrown into our cancer plan. The wealth of data we have is significant. To cover all of that would take a very long presentation, but hopefully these snapshots will help you. And I'm happy to sort of provide you with more detail after this meeting if you reach out. So the broad goals in the cancer plan are health equity, as we talked about. We're covering cancer prevention and have selected tobacco, physical activity and nutrition, HPV, and environmental factors. Early detection, we're looking at the screenable cancers and trying to impact early detection of those cancers. And prostate cancer is a little more complicated, but we're really trying to look at helping to identify ways that are, that people can identify prostate cancers that are going to be more likely to spread and have an impact. For therapy and supportive care, we're looking at sort of measures to look at traditional therapy, integrated medicine, and palliative care. And then survivorship and advanced care planning, physical and emotional health of survivors, hospice care, and then sort of advanced care planning more broadly. And so under all of these goal areas, we have measurable objectives and strategies for sort of addressing these cancers, these cancer measures and making an impact. I urge you to start, I think on one of my original slides, I put in a link to the cancer plan redefined on the health department website. I urge you to sort of go in and look at the specific measures. I know we don't have time to go through it all, but I hope you are able to check it out at some point. So, I'm almost wrapping up, but I don't have a lot of time to talk about implementation, and Maine and New Hampshire are going to get a little bit more into those factors. But in reality, sort of there's hundreds of people and organizations that implement the cancer plan. We do it through our coalition, through our Department of Health programs, and through many of our external partners. And even some of those partners are not aware that they're working towards the cancer plan measures. And this is where we're always trying to identify those partners, wrap them into our coalition so we can better collaborate and have a bigger impact. And so that's why I put you in there. I know all of you are doing some level of cancer work. And if you're in Vermont, we hope you're involved with us, and even outside of Vermont. We are a region, and so would love for you to sort of reach out if you're interested in learning more or getting more involved in our coalition. Gary Stein has been an active member of our coalition. He was a co-chair for a long time. He's a member of our steering committee, and so he's also another person you can reach out to if you have more questions. So I'm just going to end on this note that our coalition is running some summit training series starting next Friday, and we'd love it if any of you want to attend. I'll make sure that this invite can be sent out after this meeting, and hope you can join us. I know that was really quick, and we'll have time for questions at the end, but I'm going to turn it over to Melanie Feinberg from Maine to talk about their partnership. Thank you.
Thank you, Sharon. I'm going to focus our few minutes, Maine's minutes this morning, on really coalition partnership. I want to acknowledge, first of all, Maine's cancer leadership team. I'm a newcomer to public health, having only just arrived 6 months before the pandemic at the Maine CDC, but I am very grateful to my colleague, Marikita Holman, who is the program manager for Maine Breast Cervical Health Program, to Janine Bonk, who is the program manager for the Colorectal Cancer Control Program. We have a new leader for the Maine Cancer Registry, Dr. Carolyn Bancroft, and of course, my colleague in Comp Cancer, Becky Pierce. We do not have as integrated a program model as our colleagues in New Hampshire have, but we are striving to be a little more integrated, especially with our next grant application. Can you give me the next slide, please? Terrific. So we too, like Vermont, have just published another cancer plan. It's our 5th, and it coincides with our 20th anniversary of our program. That's not accidental. Our plan also includes, goals, strategies, and objectives. We have performance metrics, excuse me, that we're very excited about, a number of data resources, including the behavioral risk factor surveillance system, some environmental health tracking metrics. One of the metrics that I am most excited about in this new plan is actually the percentage of patients treated at COC, Commission on Cancer Program hospitals. That's not something that Maine's looked at in the last 20 years. And we've struggled in previous versions of our cancer plans to really come up with a metric to make us feel good about access to quality cancer care. So we're approaching it this way this time around, and we're excited about it. The other thing I'm most excited about in terms of this program, cancer plan implementation, is a recommitment to a comprehensive evaluation strategy. That was absent in the last plan, but both our coalition and other community stakeholders, our program evaluator, we are committing to a comprehensive evaluation strategy. We're going to go beyond evaluation plan metrics. We have a coalition engagement membership survey in the field right now. And at our May spring membership meeting, we're actually going to be doing some ripple effects mapping with our evaluator. All of this is going to be packaged together, and we're going to put together a 1-year report, comprehensive cancer plan, 1-year implementation report for our fall meeting. So next slide, please. Our coalition, I think our current state of our coalition is thriving because it is a dynamic and it's constantly evolving. We really have embraced a collective impact strategy, and we are pretty aggressive in our pursuit of funding partners, and we look for synergies. This is more or less what we looked like when we went into our cancer plan update, although we're going to have to update this bubble slide before the May meeting because we look a little different now. I'm just going to give you a couple examples, and again, this is to point out sort of co-funding strategies and synergies. At the time of our cancer plan update, we didn't have an active palliative care and end of life committee for the coalition. So we actually went to our state of Maine Palliative Care and Quality of Life Advisory Council, and they were more than happy to invite us in. We had time at their meetings. We updated those objectives in the cancer plan. And it worked out so well that we're actually going to be continuing to partner with them moving forward. Another big change is the evolution of a new coalition, Maine's Association of Community Cancer Centers. Now, all 13 of Maine's community cancer centers are organized, and they are recipients of a coalition mini grant right now where they're exploring organizational structures. I'm hoping that they come up with a structure that is fundable. And, you know, hopefully we have a mixed audience today, and I would just put in a plug. Our federal funding, cancer program funding, is encouraging us to seek out non-traditional partners, although at least in the state of Maine, our current state contracting practices really have some catching up to do in terms of diversity, equity, and inclusion. So a lot of work to be done there. In Maine, we are having a conversation about revising contracting strategies, but again, we're not quite there yet. Next slide, please. Just a real quick nod to what Maine looks like. And again, you'll start to see just how closely Maine is connected to coalition. Last year, Maine Breast Cervical Health Program celebrated 25 years. The colorectal cancer program, this is kind of a misnomer, new in July 2020. It was actually newly restored in 2020, and we're going to get into some of those details in a minute. Our program birthed in 2002, and that was not a coincidence that it was 1 year following the first cancer plan. And again, I mentioned our cancer registry has new leadership. Dr. Carolyn Bancroft, we gave her a couple of months to get her feet under her before we recruited her as our new chair of our data team for the coalition. And again, another synergy, another partnership. Our cancer registry needed a statewide advisory group, and our coalition was able to provide that service. So we're very, very excited to be moving forward with that new structure. Next slide, please. Now, just a little bit, taking you through our timeline. Our coalition was established in 1999, and it's really interesting because it was actually established because the program manager of Maine Breast Cervical Health Program and a US CDC intern mobilized a group of community stakeholders to write the first plan. They published it in 2001, and that same group of individuals very quickly pivoted to submit a successful application for the first comprehensive cancer control program in Maine. Next slide. During our second cancer plan, the 2006 to 2010 era, this was a really exciting time for our coalition. One of our blue bubbles at the time was a dedicated task force on colorectal screening, and we were fortunate enough to have a GI doc from a small mid-coast hospital and a medical oncologist who co-chaired that group and who helped Maine put together the first application for the Maine colorectal cancer program. And we were successful. We got a 5-year grant, and we were really making strides with colorectal screening. Next slide. Then what happened? In 2011 to 2015, our third cancer plan, by the end of this 5-year period, there were definitely, I'd say, shifting priorities. The state of Maine had a new administration. We did submit a successful reapplication for colorectal programming, but when we received our award, the state of Maine actually gave it back. And that was really a pivotal moment for the coalition and the cancer programs of Maine. Nobody really was happy about that. And it came at the same time of an announcement that there was going to be no longer any funding for our coalition. So, the end of 2015 was really sort of a very low point for relations between our Cancer Coalition and our program. Next slide, please. The fourth plan, unfortunately, the 2016 through 2020 plan, I kind of refer to it as the straw that broke the camel's back. This was published. It was true that the content teams of the coalition had submitted drafts, but there wasn't an iterative editing process. And when it was published, it really wasn't seen by the coalition to be representative of, a partnership. It was seen as the state of Maine's cancer plan. To make things worse, there was a hiring freeze in place, and neither the program that I'm with, the Cancer Control Program, or the Cancer Registry had a program manager. And really for these few years early on, there was no comprehensive cancer plan coalition evaluation being done. Now you may be asking yourself, then why did I title this slide Coming Back Together? I think what happened during this 5-year period is really, I guess, the best testimony of the power of coalition work, because while the state of Maine was sort of taking a step back and doing its thing, the coalition was thriving, and they reached out and adopted a partner, the Maine Cancer Foundation, who agreed to provide backbone support and infrastructure. Maine Cancer Foundation was shifting their grant-making model from research to cancer patient and cancer program support. And they were seeking funding partners and partners for the work. The coalition produced a listening report in 2017 and really went about the business of educating themselves and their members on the collective impact model. This was sort of, the beginning of sort of coming back to the table and having conversations. And our program at the time decided to do a partnership evaluation, working with our program evaluator in the coalition. And again, coming back to the table, having some more dialogue. And this led to, in the spring of 2019, sort of a re-recognition, if you will, of Maine's Impact Cancer Network as our state coalition. Just to give you a little update on what happened with our colorectal program, we did successfully submit another application. We restored our funder in 2020 and giving us a complete complement of cancer program funding. During this 5-year period, I will say in the colorectal space, our coalition and community partners, especially COC hospitals, took up the American Cancer Society pledge of 2018 by 2020, of 80% by 2018, excuse me. And in 2018, Maine was now #1 in colorectal screening. We slipped down to #2 in 2019, but this was actually sort of a handicap for us as we went into that grant cycle, and we had to seek partnership with Maine's federally qualified health centers. But, again, during this time when Maine had no federal funding for colorectal screening, our Maine Cancer Foundation invested $1.6 million in colorectal screening programs across the state. Next slide, my last slide. Our new cancer plan was kicked off in spring meetings in May and June of 2019. We had excellent engagement from the beginning. I actually was eavesdropping on a conversation at that meeting and overheard about this job, and that led me to arriving at the Maine CDC in the fall of 2019. The first thing that I did was pick up the colorectal screening grant application, and we did submit a application in March of 2020. And, the story continues because we were successfully funded, but for those like those in New Hampshire and Vermont who are doing the colorectal program, there is no funding for actual colorectal screening in this program. So once again, Maine Cancer Foundation, our coalition, stepped up with a companion grant to supply free fit kits and also funding to train staff to process those kits on site. And that just brings me, next slide, please, my final slide. Just a reminder to all of us, not that we need a reminder probably, but this is a page out of the American Cancer Society Fact and Figures for 2021. The gravity of what we're facing now in terms of the impact of COVID-19. Oh, time is up. Excellent. And thank you very much for your time and attention. And I will turn this over to my colleague, Adriane, to talk to you a little bit more about what's going on in New Hampshire.
Great. Thank you, Melanie. That was great. So I'm Adriane Burke. I'm the Cancer Programs Manager for the state of New Hampshire. And let's see if you could move to the next slide, Sharon, that would be great. So I thought that I would start my talk out today. I'm going to be diving a little bit into some of the projects that we do within Comp Cancer, since both the cancer plan and the cancer collaborations have been covered by Sharon and Melanie. So I figured the way that I would start today is really talk about our program to start. So we have, and Maine and Vermont also have the breast and cervical cancer program, the cancer registry program, as well as the Comp Cancer program. But the reason I wanted to show this slide here is because in New Hampshire, we are very integrated between our programs. So we collaborate on so many of the projects that we do to make sure that we are getting the largest reach and the biggest impact that we can. So while we only have 2.5 staff on Comp Cancer, really our program is much bigger and we're able to utilize the staff across programs to implement some of this work that we're doing. Next slide, please. So I did want to touch a bit on what we are doing with our Comp Cancer collaboration, as well as our cancer control plan. So currently our collaboration is in a period of rebuilding. We had some changes that had to be made in our last 5-year application, and we're still trying to figure out how we're coming out of that. As of right now, we're working through a series of work groups throughout the state, but we are actively working on getting this back together. Our Comp Cancer control plan it expired in 2020, but we did decide to hold off on redoing the plan until we had our collaboration up and running again. We thought that this was really essential because we wanted to have our partners be a part of that plan. We wanted them to be invested in the plan. We wanted to know what their priorities are so that we can make sure that the plan that we develop is the best plan possible for our state. So both of these things we are putting a major focus on as we speak, and starting in our next fiscal year, which starts July 1, we should really be moving on both of those. All right, next slide. So the way I wanted to talk about the projects that we've been working on in New Hampshire is the way I wanted to start this out is by talking about the comprehensive cancer priority areas. So this is a slide that I actually took straight from the CDC. So there are 3 areas that we focus on: primary prevention, early detection and treatment, and cancer survivorship. And then, as has been mentioned before, we have a health equity focus across all of those. You can see the 3 red arrows I put there, and those are the projects that I'm going to be talking about in the next few slides. So nutrition and physical activity, recommended cancer screenings, and then also survivorship programming. Next slide, please. So looking at primary prevention, our goal has been to improve nutrition and physical activities, both in schools and workplaces, really putting the focus on low income schools that have like high percentages of free and reduced lunch. So we've done a few school nutrition projects, both in licensed childcare programs in public schools. Licensed childcare programs, we've really focused on Head Start programs, and then public schools, again, those schools that have a high percentage of free and reduced school lunch. And here we've done some great things. So we've given food equipment to school cafeterias to make it easier for them to prepare healthy snacks and lunches for kids, playground improvements, gardening programs, things like that. We've also been working on distributing water bottle filling stations throughout the state. The focus here has been to increase water access for kids throughout the day, increase water consumption, which in turn reduces sugary beverage consumption. Again, with the overall goal for both nutrition, both school nutrition and water bottle filling stations to increase healthy lifestyles that can really take these kids throughout their life and reduce long-term cancer risk. And then our third program here is a worksite lactation project. So we worked with employers throughout the state to help them create lactation spaces and breastfeeding stations at their work sites so that women can breastfeed and pump as necessary throughout the day. So these are what we considered mini grants to create the lactation rooms. We worked with 35 work sites, 42 lactation rooms were created. And you can see here on the right, a great little picture of a storage closet that was at one of the work sites that we were able to completely transform into a lactation room. And a couple of the things we really focused on were having mini fridges in there to be able to refrigerate your breast milk and access to a sink and making sure those spaces were private. Next slide, please. So our work around early detection has really focused recently on breast and cervical cancer screening rate. And here is where that partnership really comes in. We really partnered with our breast and cervical cancer program in New Hampshire to help enroll people into the free screening program. So in New Hampshire, as well as Maine and Vermont, we all have breast and cervical cancer programs which provide breast and cervical cancer screenings, diagnostics, and enrollment into Medicaid at no cost to people who are below 250% of the federal poverty level, and either they don't have insurance or they are underinsured. And by underinsured, we mean they just can't afford that copay or deductible that they may have on their insurance. You can see this map over here on the right side. Those red dots are all screening sites that we have throughout our state. So we really want it to be easily accessible for people. So we did a few projects to help get the word out about our program and enroll people. So we recreated our campaign materials so that they were site specific, so that when someone sees our flyer, they can say, oh, that's my local clinic that I go to for my other health needs. I see that they have this program. I feel comfortable going there, so I'm going to enroll in this program. We also did a lot of social media and marketing efforts. Bus wraps in Manchester, New Hampshire was one of them, which really is among our priority population there. Another focus area that we've done is trying to engage the LGBTQ community. So we wanted to make sure that providers are comfortable and know the recommendations around screening this population. So we held a Prevention with Pride event earlier in the fall that had a patient story of a trans woman. We had the Fenway Institute come in and give a cultural competency training. And this was geared towards providers and clinic staff. We've also engage some clinics throughout New Hampshire that really focus on the LGBTQ community, and we've enrolled them into our program. And then finally, we've done some outreach through social media platforms, including things like dating sites that really outreach to the LGBTQ community. Next slide. And this is the last area that I wanted to talk about. So cancer survivorship has been a big focus of CDC's and therefore ours in New Hampshire and Maine and Vermont as well. So over the last 4.5 years, we've been trying to understand some of the challenges of cancer survivors in New Hampshire. And by cancer survivors, we mean anyone who is currently undergoing treatment or is post-treatment. So we started out by trying to understand what the problem is. We did a lot of information gathering. We did a statewide survey that we had over 500 cancer survivors respond to. We did survivor interviews with over 40 individuals. We tried to learn about the experiences of childhood cancer survivors by interviewing their families, as well as folks who are now over 18 but had cancer as a child. And then we also did provider interviews. So people who are oncologists or work with cancer survivors to understand things from their perspective as well. We analyzed all the data. You can see here just one little snippet of the data that we have here that we collected. And then we took all that data and we're currently doing some program implementation around it. So we've done things like partner with the YMCA to get people enrolled in lifestyle programs because we know that nutrition and physical activity are things that they need. Survivorship programming is something that they need. We also saw people really show that they needed greater access to mental health services. So with taking all of that into account, we partnered with the Y. We have been meeting with survivorship leaders to understand what they are currently doing and to connect them with one another so that they can refer patients as they would like to other programs. And then we're also doing planning for future years. So we're figuring out how to include survivorship in our upcoming cancer plan and how to get the data that we collected out to survivorship experts throughout the state. So that's it for me. If we flip to the next slide, I just want to say thank you to everybody for joining. And here's the contact information for myself as well as my partners, Sharon and Melanie in Maine and Vermont.
Wonderful. Thank you all so much. This was so interesting. I learned so much. I got such a better perspective of what you all do. I don't see any questions in the chat, but let me know if you do. I'm sure that Gary will have some. I'm also going to start off with a question for all of you, which is, you've all touched on different challenges, many different challenges, but if you could tell us it's a huge variety of different people here, but what is maybe the biggest challenge that you have that you think we could help with, or that you just want to share that we should know about? I don't know if it's financial or communication or something like that, but I would love to know, like, what are your biggest headaches, biggest challenges?
You can get partial credit on the exam, by the way.
What's that?
You can get partial credit on your answer.
I can go first to talk a little bit to Mona. And I think the biggest challenge is probably resources, not necessarily as money, but staff, which is money in the end. But, we have our small states don't get a ton of money for comprehensive cancer control because we're small states and small populations, but that also means small staff and only a certain number of people to do the work. And so we do facilitate partnerships and bring partners together, but that does take organization and staffing and work to sort of help prioritize. And so I think that's a big challenge. Also, a challenge is just the breadth of the work, addressing cancer from prevention to end of life care and like where you focus. You can't do all of it, and so that's another big sort of perennial challenge that our coalitions and our states and really try to figure out how to best do our work and focus our work.
I would add to that, of course, funding is a huge challenge for a small state, but also good data, actionable data at the granular level where we can actually, track our interventions for certain populations. And we're not where we need to be in Maine. And it's very, very expensive. We've made little investments and coalition partners have made little investments in Briefus, et cetera. But it's not something that we can support on our own with our program budget. So we all need to, do more work in getting more granular data.
Thank you. And I would add to that as well. I think that one of the challenges to getting some of that data that Melanie was just talking about and implementing some of the projects that we've been talking about is just how rural all of our states are. They're so rural, it's hard to get down to that level that we'd like to really understand what some of the challenges are, especially when you're talking about specific minority groups, right? So it's hard to get that data and that information.
Yeah, thank you. That makes sense. We'll let Gary go for the next question.
Well, all three states have really made significant progress in terms of meeting goals for screening, establishing programs for survivorship, and then came the pandemic. So the question I have is, what are the approaches that each of your programs are taking to try to restore the momentum that we had in place before we encountered the types of delays that have over the past few years?
I can start again. Yeah, so I think the biggest piece for us is to get back to full staffing and just like really try to get sort of our full staffing, and then to sort of be more targeted in bringing our partnership back together. We certainly have been, our coalition has been meeting regularly, but it's been a bit fragmented for 2 years. A lot of that Department of Health staff got reassigned to COVID, so it was, fragmented, and then it's changed how we do our work. We aren't meeting in person anymore yet, and so I think that is another big piece. One of the things that I'm hoping will work for Vermont is these upcoming meeting series that are starting next week. It is in lieu of an annual meeting that we would normally hold in person. And I'm really hoping that this will be sort of this kickoff for us to really try to sort of coordinate our efforts again around the new cancer plan.
And I'll just add, 2 things from Maine. We did, reestablish our colorectal program funding in 2020, just in the nick of time, I would say. And I think that our coalition, to echo what Sharon said, we haven't had a membership meeting in 2 years. So, we published a plan. Ordinarily, we would have had a big face-to-face celebration, commemoration. Everyone shows up when you're updating the cancer plan. It's keeping them around for the next 5 years to help you implement the cancer plan. That's challenging. So I'm really looking forward to our half-day membership meeting in May. And then, our plan is to have a full-day membership in the fall. And hopefully it'll be some type of hybrid where some face-to-face might be possible. But, we're a group of convener and facilitators, and it's really, Zoom works just great, but there's really, we're all anxious to get back into a room together, I think.
Yeah, and I would say that we've had challenges across the board just with where people's priorities have been over the last few years. So the employers that we want to work with, they have so many other issues due to the pandemic. The clinics that we want to work with, their staff have been completely put on COVID response, right? So there just hasn't been a focus on anything other than COVID over the last few years. As we get out of COVID and we're trying to figure out how to live with it, people are putting their priorities back or figuring out how to get things to where they need to be, back to where they were beforehand. So we're starting to see people more engaged with our programs.
Yeah, that must be a huge challenge. I know that's hit Maine Medical Center, yes, and derailed many things. I don't know, Gary, if you have another question, but there's a question in the chat. Unless you're muted, Gary. Wait, Gary, you're muted. Yeah.
Not anymore. Okay, one quick question. One of the shared challenges that 3 states have is being able to accommodate the requirements of our rural populations. What are some of the approaches that each state is taking to make certain that rurality is not going to be shortchanged?
In Vermont, I think the biggest piece is trying to sort of identify areas of higher burden in certain cancers. And I'm wondering if it gets at that first question that someone, that Heather Fairfield put in there. I think looking at our burden, which areas of Vermont are facing a higher burden, and really trying to piece out that rural versus urban or semi-urban in Vermont, and helping to prioritize that work, trying to draw in partners from those areas. We tend to be heavy on partners in Chittenden and Washington counties in our coalition, and really trying to draw in outside partners and utilize our local health offices regionally. And I think getting at that first question, since we don't have a ton of time, I think diversities in cancer. I mean, we're always trying to use data to sort of help set our priorities, including looking at regions, but also looking at cancers that are of the highest burden, the areas of the biggest need, and helping to use that to have our coalition set priorities. And that even includes, if we're looking at data, and we know that tobacco use is a huge issue, but we have a fairly active tobacco control program housed out of the Department of Health. Maybe our coalition wants to sort of try to focus on something else that's not quite as well handled. So I think we're looking at populations the same way. We really try to use data to help us make decisions. And that answers some of that question, I guess. Melanie or Adriane, go ahead.
Well, again, just to bring colorectal in as an example, we couldn't, although we had a letter of support from Maine's 3 largest healthcare systems, none of them could produce data below 75% colorectal screening rates. And the requirement was a screening rate below 60%. Well, the 18 Maine federally qualified health centers serving the rural populations primarily, half of them had screening rates below 60%. And that's not an area that we were even really focused on. So I think it was a wake-up call, and we needed to shift direction. Our own Maine breast cervical health program lost 1,300 patients with the expansion of Maine Care. That's a great thing, but we weren't really prepared to backfill those patients. We weren't really ready to be in the most rural areas. In our new grant, we're hoping for some more funding to focus on disability population, as well as some work with Maine Prisoner Network. But it's a challenge. When you get down to really, really small numbers, it's hard to come up, like Adriane said, with good strategies to have an impact.
And I would say that one thing, like, we do definitely look at rurality as one of the areas that we focus on, but we have a tendency to look more at poverty level and areas with higher rates of unscreened individuals, which often doesn't translate into working with the rural community. So that's a challenge. One thing that we do in New Hampshire is we do partner quite a bit with our federally qualified health centers, which are scattered throughout the state. So that's one way that we work in rural areas. And then we're also, for cancer survivorship, we know that rural areas don't have access to a lot of those programs. So we're looking to figure out how we can make some of those programs virtual, which isn't ideal for everybody. Being in person is often wonderful. It gives you a different experience. But for those people who have to travel 2 hours to get to a survivorship program, online may be one way to address that.
Thanks, Adriane, and all of our speakers. I'm not sure, Sheila, if you really want to end at 1 or if you want to go over a little bit. We can go over a little bit. Okay, there's some interesting questions in the chat. I was just wondering, Adriane, specifically related to your work and maybe everyone's, but the slides you showed, it looks like a lot of the work you do has prevention that would really affect a lot of diseases, not just cancer. So obesity, diabetes, cardiovascular disease eventually. So how much do you partner with other organizations that are outside the cancer field that might co-fund some of these ideas and actions that you're taking, especially in the schools? I think that sounded really amazing.
Yeah, that's a really wonderful question. So we partner quite a bit, especially within the state, to do some of these projects. Specifically, we work very closely with our diabetes and heart disease program, and I actually came from that program, so I'm very familiar with the staff. And so did Scott, who is with the cancer program now. So some of these programs actually started out with the heart disease and diabetes program. For some of the schoolwork, we partner with our Department of Education. We partner with Keene State College, University of New Hampshire Extension. So we really do try to get as ingrained as possible with the community and our partners out there to make sure information is getting out there and everyone's aware of what we're doing.
Yeah, that's great. I think that makes sense. I don't know if anybody else wants to chime in. Sharon.
Yeah, no,
Okay.
we do lots of similar work within our department, our health department. You know, our states are small, so we do have a lot of chronic disease programs funded by the CDC through separate funding streams. But we're all housed in the same section of the Department of Health, and our goals are to sort of overlap and collaborate a lot because we do have, yeah, a lot of those prevention measures are related to other issues, like you saw on my data slide. It's cancer and then cardiovascular disease, like 2 causes of death, and that work that we do. The Department of Health in Vermont has adopted this 3-4-50 campaign. I don't know if any of you have seen it, but it's, you know, we know that 3 behaviors, it's tobacco use, you know, physical activity, lack of physical activity, and poor nutrition lead to 4 diseases: cancer, heart disease, stroke, and lung disease, and that lead to more than 50% of deaths. So that's one area that we've really tried to sort of work on to try and coordinate the prevention related approaches to, addressing chronic disease. And it's always a big goal to be collaborative. And we work hard towards it. There's always room for improvement.
In Maine, when we published our plan in July, we realized we had absolutely no activities going on in the alcohol and cancer arena. So we are partnering right now with our sister program to pull off a spring conference. And we have recruited a keynote speaker, David Berrigan from the National Cancer Institute. So but this is all new work, and it's work that wouldn't really be possible, I don't think, unless we were partnering with another agency, and luckily we're all in the same building, and it's going to be I think a productive partnership.
Michaela, you're muted.
I'm sorry, I thought I hit that button. That makes a lot of sense. Thank you guys for sharing all that. Since we're a little bit over, I think that we might wrap up. But everybody can feel free to reach out to you guys. I think you shared the email. All of these slides will be available, so you can see the chat, but we'll be able to see the PDFs and the slide recording for anyone who missed it. So please share it with your colleagues if you think that anyone would like to see this. And thank you guys all for attending, and thank you so much to our speakers for great presentations.
Thank you very much.
Thank you, everyone.
Thank you.
Have a nice weekend.
Thanks, you too.